Hello, welcome everyone. My name is Eduardo Franco. I'm a cancer epidemiologist at McGill University, Montreal in Canada. And I wish to welcome you to this education activity on preventing HPV-associated cancers by maximizing vaccine uptake. And I'm joined today by Professor Lynette Denny from South Africa and Professor Daniel Kelly from the UK, two distinguished experts on this very topic here. Let's get started, but first let's discuss the benefits of HPV vaccination and how vaccination can help prevent adult cancers from a young age. So let's talk about what the virus that causes these diseases. HPV is a DNA virus that can cause cancer. It is a very common sexually transmitted infection. Roughly 80% of people acquire HPV over a lifetime, and mostly via sexual contact, skin-to-skin contact or skin-to-mucosa contact. But the vast majority of these infections are asymptomatic and spontaneously clear within 1 to 2 years. And the HPVs, they belong to a large family of viruses. There are over 200 types of HPV, of which 12 to 14 types roughly, they are considered high-risk types, oncogenic or carcinogenic, if you will. And that includes the most carcinogenic of them all, the types HPV 16 and 18. Some people call them strains. And in general, we know it has been decided now after decades of research that HPV infection is the root cause of roughly 5% of all cancers worldwide. And this varies by cancer type. For instance, all cervical cancers are believed to be caused by HPV infection. Thus, it's a necessary of cervical cancer. And the same is likely true also for anal carcinomas, and a little less so, about 78% of vaginal cancers are caused by HPV, about 53% of penile cancers as well. And then for oropharyngeal and vulvar cancers, there is some variation, about 13 to 60% for oropharyngeal cancers. This varies geographically, from 15 to 48% for vulvar cancer, and about a little less than 5% for oral cavity and laryngeal cancer. So undeniably a very important cause of cancer indeed. So with that background in mind, so let's now have a discussion. I'm delighted to welcome our faculty, Professor Lynette Denny and Professor Daniel Kelly, and they'll both discuss this topic based on questions that have been submitted from a pre-canvassed target audience. So let me start with the first question. What does the HPV vaccine consist of, and how does it prevent HPV infection?
Thank you for the question. The HPV vaccine consists of a protein known as the L1 protein, which is coded for by the virus, and it assembles these L1 proteins into what's known as virus-like particles. These particles, when they're injected into the body, induce what is known as an HPV type-specific neutralizing antibodies. And essentially, antibodies are antidotes to the antigen. So when the person is exposed to the HPV virus, the body will immediately produce these antibodies that will immobilize and prevent that vaccine from entering into the body. And what's also very important to know is that the vaccine induces very, very high levels of antibody against the human papillomavirus, much higher than are induced by natural infection.
And given how good they are, how many HPV vaccines have been pre-qualified for use by the WHO and that are commercially available right now? Are any key differences between these vaccines?
So currently there are 6 different vaccines that have been either WHO pre-qualified or they've been licensed. The first 3 vaccines that have been commercially available are a quadrivalent vaccine, a bivalent vaccine, and a non-covalent vaccine. So these vaccines consist of different types. The bivalent produces or stimulates antibodies against types 16 and 18, which are responsible for over 70% of cervical cancers throughout the world. The quadrivalent vaccine, in addition, has antigens which stimulate antibodies against type 6 and 11, which cause benign anogenital tract disease, specifically genital warts. The nonavalent vaccine, which has been approved since 2014, this vaccine has an additional um, 5 types of vaccines, antigens, type 31, 33, 45, 52, and 58. The other vaccines, which have been produced in India and China, have only been available since 2020 and 2022. So data on their long-term impact are still being acquired. The data on the others and the differences between the others have now been well established.
Well, thank you very much. This is very informative. And what are the efficacy data that we have for HPV vaccines and how they prevent HPV infection, neoplastic malignancies, and other HPV-related outcomes?
Well, the data are very convincing. That's the first thing to say. But it does come with a caveat. It depends whether you're looking at high income countries with effective health systems or low to medium income countries where the data may not exist yet, the vaccination programs may not exist, and certainly the supportive systems such as cancer registries, etc., may not be mature enough to capture benefit. But for those high income countries, we know that for cervical cancer, which is the one we're interested in here today, there's been around 50% reduction in the past 30 years. Survival rates, because of benefits in treatment for cervical cancer, have also led to 87% response in early stages and 70% in locally advanced disease. And we have to think of that as a product of a sophisticated health system that allows resources for screening, public health education, etc., to be wrapped around this vaccine. The vaccine on its own won't always produce the goods. It's the supportive infrastructure that's also needed.
Well, thank you very much. And but aside from preventing HPV-related cancers, what other benefits of HPV vaccines that we can speak of?
Well, apart from the other cancers, of course.
Hello, everyone. Welcome to this session. My name is Eduardo Franco. I'm a cancer epidemiologist at McGill University in Montreal, Canada. And this is an education activity on preventing HPV-associated cancers by maximizing vaccine uptake. Now, the second topic that we'll be discussing in this series is a very important question. Who should be vaccinated against HPV infection and why? And let me give you a little bit of background with respect to this important question. And that's about the World Health Organization vaccination campaign to prevent cervical cancer. And it has established, the WHO has established that the primary target group, essentially girls aged 9 to 14 years before they become sexually active. It is vaccinating over 80% of girls who also have the advantage of reducing risk of HPV infection in boys as well. Now, we can talk about secondary target groups, which are females, women aged 15 years and older, and also vaccination of boys, older males, and men who have sex with men. And those secondary target groups, they are only recommended if they're feasible and affordable for a given country, and it does not divert resources from vaccinating the primary target group, which I mentioned are girls 9 to 14. So in all, implementing this strategy could potentially prevent 60 million cervical cancer cases and 45 million deaths over the next 100 years. Now, as far as the schedules by the World Health Organization, the recommended one is based on 2 doses for the primary target group and older age groups for which vaccines are licensed. And the spacing between the doses has to be at least 6 months. There's no maximum recommended interval between doses. Now, as far as the alternative schedules go, there's a single dose vaccination which has been recently approved by the World Health Organization, but it is off-label. So girls and boys aged 9 to 20 years, it's off-label use of the vaccine. And for those that are licensed as 2 or 3-dose schedules. It's very important also to underscore the importance of protecting immunocompromised or HIV-infected persons, at least 2 doses, 3 if possible, regardless of age or antiretroviral therapy status for those who have received them, and 6 months or longer between the 2 doses. Currently, there is no evidence to suggest that a booster dose is needed after the primary HPV vaccination, except for those high-risk groups that I just mentioned now. So with this background in mind, now let's start a discussion with our distinguished faculty, Professor Lynette Denny and Professor Daniel Kelly. These points for discussion, they include pre-canvass questions that were submitted by a target audience. So let's start with the first one. How does the World Health Organization position on HPV vaccination compare with regional guidelines?
Thank you for the question. And as Professor Franco has just pointed out, the WHO position is to focus on girls under the age of 15, and that we should vaccinate at least 90% of these girls if we're going to have an impact on eliminating cervical cancer. But there have also been calls to vaccinate boys, and there have been calls for vaccinating older women to increase the coverage. However, the focus should remain on girls so that, because they are the ones most likely to have disease associated with HPV later in life. So what the regional positions are all context specific and resource specific. And the greater the resources, the greater the possibility of extending the people who can or should be vaccinated, such as what is known as catch-up vaccination, where girls older than the age of 15 to age 25 are also vaccinated. The problem with expanding the target audience for vaccination is that there has in fact been a supply chain problem with insufficient vaccination doses and vials being available. And the people who suffered most from that were those living in low and middle income countries.
And thank you. And with that in mind, now we also, there is some variation in vaccine scheduling. How does that impact outcomes?
Well, I think again there's an element of reality here that where do we target? Where do we send the resources that we have available? It's now in Europe, and I speak from the European perspective. WHO Europe have now recommended a single dose, and a single dose has been accepted because the evidence suggests that it at least offers widespread delivery across populations. Whether that provides longer term protection is as yet unknown. But saying that, there will be groups that will need more than one single dose. Those might be people who are immunocompromised or who are more at risk and who can perhaps access the vaccine through other ways.
Now, that's very important indeed. But what are the benefits of vaccinating males against HPV? And if you could speak a little more also about people with HIV?
Well, the argument, we in the European Cancer Organization have taken the line that it's a human rights issue. Both groups should be offered this vaccine. And that was the argument made to the British government, actually. I think it was 2017. They were only vaccinating girls, and now they vaccinate boys. So this gender neutral approach is one that we argue provides the best blanket protection across all sectors of the population. Now, people who are most at risk of the damage are people who, as I say, were immunocompromised. So HIV certainly is in that sector. Obviously, if the virus is undetectable, then they may not be quite so at risk. But people with a high viral load will be susceptible to some of these effects. So we would say that it's probably a case of targeting those protections towards the groups in the HIV population who are most at need.
Vaccinating HIV infected individuals is a critical part of the strategy for reducing HPV associated disease. And we do know that in HIV infected people, the risk of HPV infection is much higher, and the risk of progression to precancer and ultimately to cancer is much faster and occurs at a younger age. So, vaccinating HIV positive individuals is a critical part of the strategy. And in fact, there have been a number of studies that have looked at the safety and the immunogenicity of HPV vaccination in HIV positive individuals, and they've shown that it's not inferior to those who are HIV negative.
Is there any optimal age or cutoff for vaccinating?
Certainly, I think the evidence suggests that the younger children and adolescents have a much stronger immune response to vaccination than do older people. So it appears that the immunity induced by HPV vaccination is the greatest in childhood and adolescence. Vaccinating later in life is problematic because the vast majority of people will be infected with HPV at some time in their lives. But the argument for vaccinating older women, and I'm talking firstly women up to the age of 26, and then some would say to the age of 45, is that not everyone is infected with or HPV types, that's 16 and 18. So you could have been exposed to HPV 16, but not HPV 18, in which case there would be a benefit in receiving that vaccination. There has been some evidence that there is a reduction in HPV-associated disease in older vaccinated women, but again, it is a resource issue. First, the most important group to vaccinate is girls under the age of 15. The next group is the catch-up group between the ages of 15 and 18 and possibly to age 26. The next group would be males, and then the next group would be older women. And if we learn from the hepatitis B vaccine story, in fact, it was only once hepatitis B vaccination was included in infant vaccination that it became almost 100% coverage of the targeted population. So we don't have data that justifies vaccinating infants, but that may be something to consider in the future.
Indeed, indeed, so true. And it's important to take our lessons from other, the experience we have with other vaccines and how we deploy them. So thank you both for this great discussion. I greatly appreciate your time, and I hope this session was useful to all of you. And please join us for the other two sessions in this very series about HPV vaccination. Thank you all. Hello, everyone. My name is Eduardo Franco. I want to welcome you back to this educational activity on preventing HPV-associated cancers by maximizing vaccine uptake. And the topic that will be discussed here today is barriers to HPV vaccine uptake and how they can be overcome. As you can imagine, vaccination coverage varies globally. There are countries in North America, parts of South America. Australia was a pioneering country in terms of vaccination. There's very high coverage, close to 100% in countries such as Canada, Australia, and many Western European countries, Scandinavian countries, South Africa, for instance. But we do have important gaps in coverage in uptake of HPV vaccination, in addition to the fact that many countries have not even started to deploy HPV vaccination. So even though the targets are very ambitious, we have a long way to go in deploying HPV vaccination. Now, as far as the barriers to attain success in having high vaccination uptake, there are some, and we can look at those from uh, in terms of national, international barriers, such as, for instance, access to health care, which varies enormously across countries and even between regions. Availability of vaccines is also an important barrier. We had, of course, the COVID pandemic, which imposed important interruptions in delivery of HPV vaccination, supply of vaccines, of course, as the world has diverted its attention to other supply chains for COVID vaccination. This affected, of course, HPV vaccination supplies. Costs continue to be an important consideration. The cold chain capacity to distribute these vaccines, and of course, government political commitment from different countries. And those are the barriers primarily at the national, international, contextual level. But there are also individual barriers, such as perception of safety concerns, stigmas associated with a vaccine that's linked with sexual activity, and eventually poor vaccine awareness in general. Now, with this background in mind, so let's now have a discussion with our panelists, and I'm delighted to be joined by our distinguished faculty, Professor Lynette Denny from South Africa and Professor Daniel Kelly in the UK. We're going to be discussing along the lines of questions submitted by a pre-canvassed audience on very important points here. And let me start with the first question that I would like to ask our panelists. How tolerable is the HPV vaccine, and are there any important side effects? A key question.
Very, very important. Safety of any medical intervention is critical. And I think that the HPV vaccine, over literally millions of doses that have been administered, has been shown to be consistently safe and tolerable. The most common side effect is pain at the site of the injection, or local irritation of the skin, which is usually temporary and resolves on its own without any treatment. There have been reports of adverse events, and there is a very strong anti-vaccine lobby in the world, largely in Western countries, that have created vaccine hesitancy, as it's known, due to the fears. And the vaccine has been accused of many ills which have never been proven. The World Health Organization, which is rigorous in assessing the safety and efficacy of vaccines, have stated unequivocally that all approved vaccines at this point in time are safe, with no serious side effects and only really benefits. Remember too that this vaccine is not a live vaccine. What you're injecting into the body is a protein. It's not an organism that can cause damage to the host.
Thank you very much for this. Now, but let's address also other concerns that parents and caregivers have. For instance, that the HPV vaccine, receiving an HPV vaccine can potentially promote sexual behavior that's not ideal for that child, for that teenager. How can that be addressed?
Well, I think it's a very important point to address, because parents, I think, find it very difficult to think of their young children being at risk from a sexually transmitted virus. And I think the best way to address that is through factual education, actually, and to give people information on the benefits of this protection. Because if they were to see the outcomes of the cancers that can arise as a result of HPV, then I think some of the misinformation might fall away. But obviously, we don't want to do that. We don't want to scare people. But I think it's about giving information. We did a study in Cardiff looking at all the published interventions, and what parents and caregivers prefer is face-to-face information where they can ask questions and be reassured. They weren't so keen on printed information or online. So I think we need to have a face-to-face opportunity with parents who may have some concerns in order to challenge some of that hesitancy that might be there.
Indeed, indeed. There's no evidence whatsoever to the fact that to the notion that they could lead to unhealthy behaviors. Now, think again. Let's think now on a global scale and country level access to HPV vaccines, and this varies as I mentioned in my remarks. And to what extent does this impact outcomes? And of course, I also mentioned the COVID pandemic, which was a major disruption in delivery systems and mechanisms throughout the world. And this, of course, affected the two main ways of delivering HPV vaccines: school-based vaccination as well as in clinic-based deployment.
Sure. There's tremendous, actually, inequity of access to HPV vaccines. And as usual, in the health arena, it is low and middle income countries that take the biggest knock. And it's certainly in many low income countries, very few have been able to initiate HPV vaccine requirements. And as Professor Kelly pointed out, this is not just about putting a needle in the arm, it's about the infrastructure required and the implementation strategy so that you have the highest coverage and the most effective outcomes. But it has been able to work in some countries, such as, for example, in Rwanda, where over 90% of the target population of girls have been successfully vaccinated, as well as, for example, Bhutan, where, again, with the collaboration with the Australian government, over 90% of the targeted girls have been vaccinated. So it is possible, and with the help of Gavi, the Global Alliance for Vaccine Immunization, they negotiated the price of HPV vaccine down to $4.5. The COVID-19 pandemic had a devastating impact on existing HPV programs, and particularly in my country, in South Africa, we had reached a coverage of 86% of our targeted population of girls between the ages of 9 and 12, 86% in 2020, and in 2021 this went down to 3%. And this was a combination of school closures, of the failure or the inability to sustain the school health vaccination program, teachers being absent, loss of life, and the complete disruption of the healthcare system. And there's no doubt that the school-based vaccination programs are the most effective. However, in some countries, only 50% of girls actually go to school. So school-based vaccination programs are the backbone, but we have to find ways of bringing all girls into the vaccination orbit. And that's where, to an extent, facility-based vaccination programs could be located. Good on those who persist and are tenacious. It's coming back. And our vaccination coverage in South Africa has now gone from 3% to over 47%. So we can recover.
Yeah, this is so important. And you mentioned success stories such as Rwanda and Bhutan, which have lots of stakeholders have invested in demonstrating that this can be achieved. So what sort of strategies can we actually use to facilitate and improve HPV vaccination uptake? And how effective are these nationwide vaccination programs? Can we build resilience into them to protect them against future situations such as the COVID-19 pandemic?
Yeah, I would say that the most important strategy is to have political buy-in to this approach. And in some countries in my continent, in Europe, there's a huge variation across the continent, from very established high uptake to almost non-existent, and we're working very hard to try and help them. And on a continent-wide level, we now have a beating cancer plan with HPV vaccination included in that. So all governments in Europe, in the WHO region, will have to show that they're doing something about HPV vaccination. So I think there's a political dimension here. But also, when we think about how effective they are, I think we can look at systems that have worked very well. And for me, that's about working with young people, not always imposing this on them. So, helping peer to peer education, involving group level education of benefit, and using that double edged sword that we have these days, social media, which can spread so much disinformation about vaccination, but it can also spread so much good messaging. So I think it's about wrapping all that together, the politics, the messaging, and having the resource so that the nations themselves can peer review each other and see what they're doing and what they're failing to do. Because every young person, I think, deserves the same level of protection.
Indeed, indeed. Thank you both very much for this excellent discussion, terrific insights. And in one of the most important topics on which are barriers to HPV vaccination, which is to a large extent is also true for the delivery of other vaccines as well. And I thank you both very much. This has been a very informative session, and I hope you have a chance to watch the other two sessions we have in this very series. Thank you all very much. Hello, everyone. My name is Eduardo Franco. I want to welcome you back to this educational activity